Hello all, thank you so much for joining us for today's webinar, Introduction to the Cultural Formulation Interview in Early Intervention. This is the final session in a series made possible by BSCA funds through the Department of Behavioral Health, Developmental and Intellectual Disabilities. This series is called First Episode Psychosis. Today's session will be held for about 1 hour. And as you all know, this session will be recorded and will be posted via YouTube. In order to receive a certificate of attendance for this session for CEUs, you must attend the live training for at least 50 minutes per hour. We will allow for about 5 minutes of wiggle room because life happens. Today's webinar is led by Dr. Ryan Melton, PhD, LPC, ACS. Dr. Melton serves as Dean of the School of Psychology and Counseling, Director of Assessment and Associate Professor at Bushnell University. He is owner and operator of Endurance Counseling and Consulting, LLC, and clinical supervisor at Pace Health Hospital. Previously, Dr. Melton has served in a variety of director and university faculty positions. Thank you so much, Dr. Melton, for joining us. And just a reminder to everyone, please put any questions that you have in the chat. Dr. Melton will also allow for questions at the end of the session. And if you need any technical assistance, please feel free to message me directly. And I'll pass the mic to Dr. Melton.
Right. Good morning, or probably a little bit afternoon for you all. Apologize for my tardiness in terms of when you schedule a doctor's appointment and you think you have plenty of time, and then they show up a half an hour late, and all those things. So apologize for that, but glad I was able to join you. So today we're going to be talking about kind of using the cultural formulation interview. We'll kind of tell you what that is, how it's used. We'll touch on early intervention, but this is an instrument that really should be, I believe, for my bias out there, really should be kind of used kind of across the lifespan and should be regularly used with, I would say, almost all clients. I've found it quite helpful in an engagement strategy, as well as kind of engaging in some cultural broaching exercises with individuals that are from cultures that are different from my own, which, if I think about the percentage of that, that's about 100%. Giving kind of the definition of culture. So we'll talk about using this. In using this particular assessment, I think it's important to do a little bit of practice reflection. So I don't have a ton of slides today. I'm going to give a brief overview. I'm going to show you what the instrument is. I do not believe the instrument is rocket science in terms of how you use it. You don't need advanced degrees. I think the key in using this particular assessment is your willingness to kind of engage in what sometimes can be uncomfortable conversations. I think is much more really the skill set with using this particular interview. Oops, let me hide everything here so we can see each other better. One concept that I think is important to understand or try to move the field towards is this idea of cultural humility. Now, when I went through grad school, and I've been in this field for over 20 years now, my cultural competence class, and I think that was a title of it, the cultural competence in psychology or cultural competence in clinical mental health counseling might have been the name of the course. The term cultural competence was kind of the current nomenclature, the term that we were using, and very much well intended as a term to make us quote unquote competent, in working with individuals from cultures that were different from our own. I think the problem with it, or the challenge with it, is the term competent, because in a lot of ways it implies that you can become competent in a subject matter, or no, scratch that, in an experience that you have no experience in. I can't become competent in understanding the lives of individuals who grew up as refugees. I can't become competent being a cisgender homosexual male or heterosexual male myself and a member of the LGBTQ plus community. I can never be competent in that, despite what books I read, despite what articles I read, despite who I've talked to. There really is no such thing as competent. So we as a field over the last several years have shifted this term from cultural competence to cultural humility, trying to really use that term. Um, and the NIH, National Institute of Health, kind of defines this as a lifelong process of self-reflection, self-critique, whereby the individual not only learns about another's culture, but one starts to examine and with an examination of their own beliefs and cultural identities. Whereas I think the cultural competence model, and I literally had chapters in that text that would talk about when working with Asian patients, do this, as if every patient from an Asian country was exactly the same. And I think that was really the error that we made in the field. But really now we're at a point that this is about, we want to learn about cultures that are different from our own, because there's an incredible amount of richness that comes with the in treating individuals when we understand that, or at least willing to hear about it, as well as being able to almost kind of celebrate the differences. I might even started to change the language in some of our manuals now at the university, that I'm now using terms like our students will understand the process of cultural humility and cultural celebration. So I've started to add even some of that language in the work that we're doing. And again, also cultural humility is about bringing to conscious awareness that there are many ways to experience and manage life stressors that are unique and influenced by one's individual sensibility and culture. Now, we've always known that not one of intervention or not one technique works well for every client, even clients with the same diagnosis. We know that somebody who experiences major depression disorder may respond well to cognitive behavioral therapy. Others may respond well to taking antidepressant medications. Others may respond well to a psychodynamic, approach. Others respond well to having a life changing event that improves their life in some way. All will respond differently, because I think there's a culture in that as well. So yeah, cultural humility really is about, if I'm going to summarize it, one, self-reflection, recognizing our own biases, recognizing that we don't have a shared experience with the individual sitting across from us or walking side by side with us, as well as we have to have a willingness, or encourage a willingness, to try to understand to the best that we possibly can, without making an assumption of understanding. And that's kind of, in a nutshell, I think, what cultural humility uh, really is. So encouraging removal of dated terms like cultural competence and even culturally informed in some ways, and really moving us as a field towards becoming culturally humble practitioners and culturally humble clinicians. Yeah, so what does the DSM-5 say about this? And some of you might be thinking, well, that's ironic that you're bringing up the DSM-5, or maybe even contradictory, given some of the challenges and critiques that the DSM-5 has, around, not necessarily being a completely culturally humble instrument. And for the most part, I can agree with that sentiment. And also, will give the DSM-5 and the DSM-5 subcommittees some credit in that they were working to recognize that even diagnostic features um, are experienced differently from cultures that are not based in this westernized like culture in which the DSM-5 was developed, as well as helping clinicians who are themselves overly biased and overly influenced, and I will put myself in that category, uh, it- uh, overly influenced, overly biased about kind of medical models and medical explanations of things, that when that happens, we sometimes can miss individuals' personal experiences that have that may or may not be pathological from one's own cultural experience. The the DSM itself, as it's looked at the definition of a quote unquote mental disorder, specifically states in that definition that uh, experiences that individuals have, including negative experiences that individuals have, or negative symptoms or symptoms that people have that are exist only within the context of one's culture, are not diagnosable. They also state that if these said experiences are not causing significant clinical distress or disability within the confines of the individual's culture, that it's also not diagnosable. So, regardless of what we believe or what we may feel about somebody's personal experience, as quote unquote unusual as it may seem to us, it may in fact be part of one's kind of cultural belief. And for us to be truly humble, recognizing that culture is broad, that there are subcultures, that there are, yeah, subcultures within cultures, even subcultures within kind of a westernized view of medicine, that again can sound unusual to us, maybe in some ways a little bit disturbing to us based on our own personal experiences and biases, but also very much consistent with the individual's culture. And working with young adults primarily throughout my career, I've had the opportunity to assess. Some of you that have heard my keynotes or other diagnostic talks have heard me describe the 16-year-old vampire that I assessed, who was not mentally ill, but was in fact kind of within a vampire culture. Um, who I've assessed, had the opportunity to assess kind of furries and bronies and all these subcultures. And some of these I do not encourage you to Google at work, but they're just, but having to let go of some of my own kind of biases and own type of experiences to not diagnose somebody who is kind of engaging in a culture that is, again, our belief system that's much different from my own. So I think DSM kind of defines culture in a broad way, which I can respect, which is values, orientations, knowledges, and practices, aspects of a person's background, experience, and social context, and the influence of family, friends, support systems, and other community members. And they say that culture is dynamic and unique. Trends may emerge, but careful, trends become tropes, and understanding easily give ways to bias and aggressions. Oh, you say that because of your culture, or you say that this is this way because of how you grew up. I mean, and so we can sometimes go down that trope, or those type of tropes, um, and even define things as cultural, when in fact it may not exactly be. Our diagnostic assessments, like the structured clinical interview for the DSM-5, the SCID, an instrument that I have trained on and can train you all on, and then that's a diagnostic um, assessment that really kind of helps us uh, understand diagnostically what's happening from from a symptom standpoint, not necessarily a culture one. Same is true for the Kitty Schedule for Affective Disorders and Schizophrenia, or the KSADS, which is really kind of your childhood, your kind of your gold standard childhood disorders diagnostic system. So that helps us find diagnosis. Um, but then, how do we really understand the person, and particularly how do we understand the person within the context of the diagnosis, because our state rules, our insurance companies, they want us to make sure we have a diagnosis, because that is something that we're then scheduled to, or that we're required to treat. That is the medical model that that we are in. I of course want us to say, well, we really also need to treat the whole person. Diagnosis is a starting point. It's not an ending point. Diagnosis can help inform treatment, but it to really understand the most effective form of treatment, we also have to understand the person outside of the diagnosis. Hence, kind of the follow-up assessment, which I encourage us to be using, which is the CFI, the Cultural Formulation Interview, developed by Roberto Luis Fernandez and colleagues. And they were kind of the Roberto Luis Fernandez was the chair of the DSM-5 cross-cultural issues subgroup. So one credit that I will give the DSM subcommittees is when DSM-5 was being developed, there are many subgroups. Most of those subgroups were on diagnostic issues. There was the psychosis subgroup and the bipolar subgroup and the eating disorder subgroup and everything else. There's also the cross-cultural issues subgroup, which was a diverse group of individuals. And what they were tasked with was, again, trying to understand the person at a cultural level for a couple of reasons. One, not to misdiagnose somebody who may have a religious, spiritual, or cultural belief that is not maybe consistent or understood by primary westernized professionals. So not to misdiagnose that and call that, say, a psychotic disorder when in fact it wasn't or isn't, as well as understanding kind of the holistic person. I personally, when I use the CFI, or the Cultural Formulation Interview, I use it more to really understand the person. I use it a lot for treatment than I do for diagnostic issues. But it can be used in both ways. One of the kind of the strongest techniques that we've seen in the literature around discussing culture within the therapeutic context is this idea of cultural broaching. And what cultural broaching is almost what I was speaking to Sally about, which is that we don't ignore that there is a cultural difference between you and your client. Now, some are going to be much more outward obvious, maybe skin color, maybe language, something like that. But I argue, and I think this is now kind of supported in our broad sense of the definition of culture, that there are belief systems that aren't going to be outwardly expressed necessarily unless we specifically ask. So really kind of using a session early on in the treatment process to understand one's cultural beliefs. Now, the CFI is going to focus a lot of the questions around the cultural beliefs, around the challenge they may be experiencing. But I think when doing that, you can also understand the person. So there are a few tools, I guess kind of three tools, sorry, I said two tools there, that the work group developed. There's the kind of the short cultural formulation interview, which is a unstructured, let me rephrase that, a semi-structured assessment, in that they give you questions, but those questions can be guided by your clinical judgment, making it kind of semi-structured interview around the issues of culture and specifically how the individual's culture defines what they're seeing for. And that's an interview that you do directly with your client. Then there's the cultural formulation interview, the informant version, which looks in a lot of ways almost identical to the cultural formulation interview, the difference being that you're getting the information from an informant. Maybe you're getting it from a parent. And I had another consult, another supervision session. It was maybe yesterday or late last week, where the client was very much westernized, but was being governed in a lot of ways or influenced by their parents' beliefs and the culture that they were from. So my suggestion to the supervisee was I think it might be helpful, assuming you can get consent to do a CFI, do the informant version of the CFI with the client's parents. Because clearly, and as we were looking at the dynamic and the behaviors of the client, we were really trying to piece together that this client was being, although didn't believe what their parents believed, was being influenced by what their parents believed. And I thought for us to better understand the whole client system, we need to understand where the parents' beliefs are coming from, so we can start addressing even some of the roots of some of the distress that the client was having when they were going, what at least from my perception, looked like they were going against deeply rooted beliefs. And then the final tool within the cultural formulation interview, there's a bunch of supplementary materials that really speak to specific cultures. So you don't have to do all three. So first and foremost, you could do just the cultural formulation interview with the individual, the informant version with a family member or support person, and then, or if they were part of a specific cultural group that is covered in the supplementary materials, then that can be helpful as well. So give me 1 second. I'm going to stop share and I'm going to show you these tools. These tools are free. I want to say that too. One thing I love about kind of good, solid assessments is that they're free, that they're very easy to use, that they don't have a high level. This is not a whisk or waste. You don't need PhD level or advanced training to do these assessments. Like any one of you that has, I'd say maybe the only training I might suggest would be some training in clinical interviewing, how to engage clients, those type of things. But outside of that, any one of you can engage in doing these tools. So free, easy to use, and effective. Can't beat that when it comes to doing assessment. So they are free. If you have the full version of the DSM-5 TR, which by the way also updated a bunch. People have been asking me, what's the difference between the DSM-5 and the DSM-5 TR? They look very similar. My response is they are incredibly similar. The biggest changes from the DSM-5 to the DSM-5 TR was cultural language. They updated language. So it really was, they were trying to be more culturally humble in their language. And those are the biggest changes made from the DSM-5 to DSM-5 TR. A side note there. But let me show you these documents. I'll start with the primary CFI. I can get out of my systems here. Okay, so I hope you all can see my screen. This is kind of the introduction to the CFI. These tools are available on when they're available in the DSM-5. So you have copies of them in the DSM-5, and they're also available on the DSM-5 website. If you Google cultural formulation interview, DSM-5 or DSM-5 cultural formulation interview, you will get the same sheet that I'm looking at, right now. And I'm also happy to share these as part of my sharing of the presentation, and can send them to Hannah so you have them available, but they are readily available otherwise. All right, just to kind of look at how this is done, the CFI is kind of broken into two columns, essentially. One on the left-hand side, which is kind of the guide to you, so guide to the interviewer. Just kind of, I encourage you, as you are, before you do this, read the interview guide. That's just on the left side, and all that's explaining is what questions, or what the purpose of the questions to ask. So there's a comment to make the screen a little bigger. There we go. Hopefully that is helpful, let me know if you'd like me to make it even bigger. So that guide to the interview, again, just is the guide. And then on the right side is your instructions, basically what you say. What are you saying to the clients? Thanks, Janice. Yeah, so when you introduce it, you may make a statement like, I would like to understand the problems. And if you don't want to use the word problems, I sometimes use the word challenges. I might even say what brings you in here so that I can help you more effectively. I want to know about your experience and ideas. I'm going to ask you some questions about what's going on and how you're dealing with it. Please remember, no right or wrong answer is kind of how you're starting out. And you kind of go through the questions. What brings you here today? If the individual gives few details or only mentions symptoms or a kind of medical diagnosis, again, partly what we're trying to do here is shift them from, the primary, this medical definition of what they're experiencing. Although I fully recognize, and I've had many clients that is all they want to talk about it. And from that standpoint, that was their kind of cultural belief with it. And I would go, of course, would go with that. But if there is ways to kind of shift it, then we'll go from there. So you can do a follow-up. People often understand their challenges in their own way, which may be similar, different to how doctors, and you could say counselor, again, feel free to replace some of these words, describe the challenge. How would you describe your problem or your challenge? Some people have different ways of describing their problems, their family and friends and their community. How would you describe it to them? How would you describe it to them? What troubles you the most? And then each section of the CFI kind of gets into a different subset of what you're asking. So the second subset is the cultural perception of cause, context, and support. What do you think? Why do you think this is happening to you? Why do you think you are the cause of your challenges? Some people explain problems as a result of bad things that happen in their lives. Others with physical illnesses. Others with spiritual reasons. What do you think your family and friends or others in your community think might be causing your challenge? Next section is on stressors and supports. What kind of stressors make it worse? Next section is on, I'm not reading through everything, I'm just kind of giving you the idea. The role of cultural identity, where a really nice question of sometimes aspects of people's background or identity can make their challenge better or worse. By background or identity, I mean, for example, the communities you belong, the languages you speak, where you or your family are from, your race or ethnicity, your gender or sexual orientation, your faith or religion. So you're asking questions in that area. And then it moves into self-coping. How they have sought help in the past, barriers, preferences, and then the relationship. So again, what I hope you're seeing here is this is not, again, not rocket science. We're not trying to get Z scores here. This really is an engagement tool. This really is engaging a client in cultural broaching, kind of talking about that and speaking about culture in a very, very broad way. The CFI informant version is identical, essentially, other than the questions get shifted towards a person's care provider or a leader or uh, some other individual. The supplementary module, go over that real quick, gets into, kind of defines it there, just more depth in terms of the person's challenge. So their own explanatory model. I love explanatory models in working with clients. One of my favorite questions asked is, can you tell me more about how you understand your problem or your challenge? Whereas they may have been hospitalized, particularly in early intervention, and they've been told by a medical professional of some kind that their problem is due to a bunch of neurochemicals in their brain being out of balance. They may or may not accept that definition. And whether or not they accept that definition of their challenge can also predict whether or not they're going to engage in treatment. So whether you agree, I mean, I had a client that when I did the CFI informant version, family told me these were demons. And when I explored further, it wasn't that they were psychotic. They were not psychotic. Within their spiritual community, they believe mental illness or those type of things were caused by demons. Um, so I had to work with that. For me to come in and say, no, it's not demons, it's a neurochemical imbalance, probably too much dopamine or D12 in the specific prefrontal area of the brain. And what we'll do is it looks like the doctor wants to try Abilify, and that will try to act as an antagonist to that. They weren't going to hear any of that kind of medical definitions. We needed to go with what they believed, and they wanted to have their child have an exorcism. And so I certainly had to understand what that looked like. I wanted to talk to leaders, and I did. I engaged with kind of some of the church leaders on what could we be supportive if this doesn't work, and all that. And I went through an exorcism, as far as I know, and we followed that client for the next 2 years. They weren't psychotic again. My bias and my medical definition brain says this was a brief psychotic episode, and the fact that they went through an exorcism is all coincidence. But that's my bias. That's my kind of medical brain. But from that family's standpoint, this cured their child. And we supported them, did other forms of therapy, but they did great. So sometimes families' explanatory models can be helpful with their belief, whether this was placebo. And again, that's my bias. That's my medical brain going, how would an exorcism work? But I had to kind of let go of that. This other modules within the CFI, social networks. You can ask us about social networks. You get into more detail in psychosocial stressors, more detail in spirituality, religion, and morals the person may have, more information in cultural identity. This is kind of building off of the previous CFI informant version. And then there's some coping, more built off there, parent-client, clinician relationships. And then there's some specific populations, school-age children and adolescents. A few others in here, older adults, so immigrants, refugees, caregivers. And yeah, so just some supplemental modules that you can use either if you want to expand on your original CFI of the individual, or there's some specific population, again, adolescents, children, older adults, immigrants, refugees, that you can use those questions for those specific populations. So that is, in very short, with the time that I have, the CFI. My PowerPoint here and finish this up. If you want some additional training on the CFI, there is a YouTube video, so you'll be able to link that when you get my slides. You can also read the Jarvis article. So I put the citation for that article here. So I encourage you, just for additional training, watch the YouTube video. YouTube video is about an hour long, or read the article. Really kind of goes into a little bit more detail than I had time today to get into the cultural formulation interview. Okay, so we're a little out of time, getting close on time. So I'm going to open up to questions, but some questions that I'd love to hear from you is kind of, to what extent are you already asking questions like this? I mean, do you ask questions like this? What did you hear today might be elements that you miss when you're talking to clients about their culture. And I know you all do biopsychosocial assessments that you enter in your EHR, your EMR. Are there cultural questions in that already? Or is it what I've experienced when I look at EHRs and I see a box that says cultural issues, but it doesn't really tell the clinician what to ask, how to ask. And oftentimes that box is left with information that's like none, which I know is not the case. There's no client that exists in this world that has no cultural issues. I think sometimes when I see the word none in a box in an EHR that says cultural issues, it probably means that the clinician is perceiving the client as being similar to them. Maybe they're both white, for example. So like, yeah, we don't have cultural differences, things like that.